Well, welcome everyone. We've got a handful of D102 parents with us. We're recording this session, so we will put it on our website. We are so fortunate to have Dr. Emily Landon back with us today. She spent time with our staff on January 12th, educating our staff about adult vaccination, and she is here today to help us learn more about youth vaccination. So Dr. Landon, thank you so much for giving us a little bit of your time, and we look forward to learning from you.
Thank you so much, Lori. And thanks to you parents for being here in the middle of the summer to talk about this. It's great to have a nice small group because then you guys can represent all of the parents and ask lots of really great questions, and hopefully we'll be able to get into a nice in-depth conversation. So I'm going to start by presenting some slides just so that we have we're all starting from the same place and so that everyone has access to this sort of key basic information. So I'm going to just pull up slides here and share my screen. And I'm going to make it start from the beginning, maybe. Okay. And there's not very many slides, so this won't be too much. But let's talk first of all about why these vaccines, I think by now most people know this, but I want to make sure we get it across for anybody that's watching this and hasn't thought about it yet. A lot of people wonder why this vaccine was able to be created so quickly. And it's really important to understand that we just did it differently than we'd ever done it before, like microwaving food as opposed to cooking it in the old-fashioned way. And that is not to say that microwave food is the same quality as others. And I'm not saying that these vaccines are not as good as the others. So maybe microwaving food isn't the same thing. It's a little bit more like using macaroni and cheese from a box and trying to put it together versus starting with some wheat and a cow and just making macaroni and cheese from there, which is a significantly harder task. So when we're going to make these old style vaccines with purified protein derivatives and these sort of whole bacterium or whole virus proteins, inactivated or even live attenuated, first you have to figure out how to grow the pathogen and how to purify it and how to inactivate it. This all takes years. We skipped over all of that and went straight to just using the genetics of the new disease, because this is the first time that we've had a new disease since we developed all these tools, which are being used widely in the rest of the medicine for cancer treatments, for diseases like rheumatoid arthritis and things like that, and other things that you see these commercials for on TV. And those methods allow us to make the vaccine a lot faster. So these messenger RNA vaccines, and to a large degree the DNA vaccines, the viral vector DNA vaccines, work a lot the same way. So let's look at how this works. You've got the messenger RNA that encodes for a key protein on the virus. It's not the whole virus. It's just one little spike, literally, on the membrane or the outside of the virus that our immune system recognizes. And that's why these kinds of vaccines work so well for coronaviruses, because the spike protein is so important to the coronaviruses and the immunity that we make. So you can just code for that spike protein. So it's basically like a recipe for our own cells to make spike proteins. And that gets injected. It's inside just a little generic membrane piece so that it can fuse with our cells. And then it goes in, and our own sort of cell machinery, we're using our own, instead of trying to do all of this in a lab, we're just saying, okay, cells, immunity cells in the arm, which they exist, can you please just make some of these spike proteins for us using this recipe we've given you, and then put them on this outside of the cell? That's what they would do anyway. As they ingest other viruses, these immune system cells would go ahead and make those in order to present that to the immune system, the other parts of the immune system, so that they could make the appropriate antibodies. And that's exactly what they do. And then those spike proteins are out on the antigen presenting cells, and the immune system can come by and say, oh, let's take care of that. That's what I'm supposed to be looking for. It acts kind of like a wanted poster for the coronavirus, and it tells your immune system exactly what to look for and what to go after when they see it. The first dose gives you what we call a primary immune response. This is also what you get when you get COVID. You have this big immune response because your body sees this spike protein for the first time. That's the part that your body's going to react to. Then when you get the second dose, or if you get the vaccine after having had COVID, you get what's called a secondary immune response, which is a bigger peak. Now, you can also get that from just being exposed to COVID after having had COVID, but a lot of people don't really want to be exposed to COVID or get COVID again after they've had COVID. So most people are pretty careful, but the vaccine can fill that gap and give you that big secondary immune response and help you to fill in and be really good. That's where the memory comes from and the long-lasting immune response. So viral vector vaccines do the same thing, except instead of being inside a generic membrane, they're inside of an adenovirus outside. So they're sort of like wearing the coat of an adenovirus. They're like sort of dressed up like an adenovirus for Halloween. And on the inside, the only thing that they have is just the spike protein. And your body's does exactly the same thing. It turns it into spike proteins that it then presents to other places. So let's talk about how vaccines, once they're candidate vaccines and the process for making these vaccines is developed, and all of those processes that we just talked about have been used in the past for other vaccines, for other treatments, for other medications. And those processes have been proven to be effective in making things that you can inject safely into the body. And that's that sort of outer coating and the sort of how we get the genetic recipe into there. That is not a problem. That stuff has been known for a long time. The question is it going to be safe in that, is the immune response going to be appropriate enough to protect you from COVID? And is the immune response not going to be so much that it's dangerous for the person who's getting the vaccine? So we have to do a clinical trial. And clinical trial means we separate all these people. We ask for a bunch of people who've never had COVID or don't think they've had COVID and put them in two groups. And we say, you all in group A are going to get the vaccine and you all in group B are going to get a placebo. In other words, just a saltwater injection, something that you don't know whether it's vaccine or not. Then we scramble up all those people and then we don't tell anyone whether or not they're getting the vaccine. We also don't tell the doctors or the nurses who are caring for those patients. So no one knows what anyone's gotten, and then they follow them over time. And what they found was, well, let's talk about the requirements. In order to qualify for being approved for emergency use authorization, you have to have at least 3,000 people for at least 2 months, and it has to be at least 50% effective. That's the low bar that the government set for an effective coronavirus vaccine. That's the bar, not just for emergency use authorization, but for any authorization from the FDA. This is where we should talk a little bit about what the difference is between emergency use authorization and full approval. The difference between these two is largely red tape. The safety and efficacy, so whether or not it works and whether or not it's safe, that bar is exactly the same. You have to complete all the studies, all the data analysis, and have all the data collected and be completely finished with the same amount of data, whether you're going for emergency use authorization or full FDA approval. The difference is that people with emergency use authorization get to jump the line. It's like being at Disneyland and having a broken leg. You don't have to wait in line. You just get to go in the back way and go ahead of everyone else. It would be ridiculous for us to sit for months and months and months while FDA continued on its usual queue of the drugs that were coming in its queue to be approved. And, you're up for approval. We're going to review your case in 3 months. That's when the committee's meeting. It would be insane to just sit around and wait once the data was done for these vaccines. So that's the number one thing that emergency use authorization gets you. And you have to be in an emergency in order to be able to jump the line. The other thing it does is it skips out on a lot of the red tape, like naming the drugs. If you haven't noticed, we just call them the Pfizer vaccine, the Moderna vaccine. They're going to get names like every other drug, but they haven't had approved names yet because that's part of full FDA approval. They also don't have ads on TV or in magazines or on the web. This is because advertising has to be approved by the FDA and is part of the FDA approval. There's also a lot of language and package inserts and patient information and stuff that has to be gone through with a fine-tooth comb through multiple different committees, specialty committees and literacy committees, and translated into lots of languages. And all of that has to get approved and agreed upon before you can have full FDA approval. But the safety and efficacy, that core piece, the most important two pieces, that has to be completed 100%. And then you can skip the line and skip the other stuff, and we can just get the drug into people's arms. You have probably had other medications that have been emergency use and not realized it because they just hadn't finished because that other work wasn't necessary to get done. In this case, the Johnson & Johnson phase 3 trial had 60,000 participants in it. And that is as many people as fit in Soldier Field. So if you feel like this is still in testing or not that many people have gotten it, you're not right. Millions of people got the vaccine even before we started giving it to people in healthcare and older people. And by now, millions upon millions upon millions of people have gotten each of these vaccines. And we have been collecting data about their safety and efficacy in all of these individuals. We're required as healthcare providers to enter any reaction that a patient has within a couple of weeks of having their vaccine into the VAERS system. And I'll talk a little bit later about how that can be confusing for people, but how it's also really helpful. So this is what happened in those trials. And I'm going to talk about the Pfizer and the Moderna first. These are called survival curves. They are not the sort of graphs that you probably encounter in your everyday life, but they are really important to doctors. The piece that you need to understand here is that over time, starting on day 0 through day 112, this line represents how many people got COVID. So everybody starts out not having had COVID. And then over time, in the first week, everybody gets COVID about the same amount. And then after that, the people who received the Pfizer BioNTech vaccine, there were almost no additional cases of COVID. Whereas the people who received the placebo kept adding cases of COVID, cases of COVID, cases of COVID. That is what you need to know. Once the vaccine starts to do its job, people stop getting COVID in this group. It just stays the same. You can't stop those people from having already gotten COVID, so there's nothing you do about that. Same thing in Moderna. Both of them are the same. That's what we're looking at here. Johnson & Johnson is the only other one that we have available in the market in the United States. It's one dose, it's easier to store and ship, and it's 85% effective in preventing severe disease across all regions studied, and 74% protecting against asymptomatic disease. Now, the Johnson & Johnson vaccine is slightly less effective than the Moderna and the Pfizer vaccines, but it's still a great vaccine. The best vaccine is the one that you get. There have been some issues with blood clots associated with this, but again, these are extremely rare. And so if you're not in that age group of 18 to 49-year-old women, I wouldn't worry very much about that at all. Now, Johnson & Johnson's only been approved for 18 and up, and we're going to get to the timelines on the kids in a second. So let's talk about what can happen after you get a vaccine and how they're all in these different categories. First of all, you have serious adverse effects. That's the stuff that people really worry about. Am I going to die from something else that gets triggered because of the vaccine? Like, does it cause Guillain-Barré syndrome, a stroke, or give me an autoimmune disease down the road? This is really important. Nobody wants these things to happen. They're unintended negative health outcomes. And it's really important. A lot of people are very afraid of them. To understand that we have a lot of experience with using vaccines in the immune system. And what we have found over the ages, the 100 years that we've been using vaccines, is that all of these things show up. They start within about 6 weeks of the first dose. If they happen later than that, they're proven to not be related to the vaccine. Now, bad things can happen to people over time, but we know that these negative health consequences, no negative health consequence that starts after 6 weeks has ever been found with a vaccine before, with the exception of some delayed infections with live viral vaccines in people who develop immunocompromising conditions later. So that's a really small niche thing, and that has to do with the Salk polio vaccine, and it doesn't really have anything to do with what we're talking about, where there's no viral particles in this at all. So we are not worried about this, but still everybody followed those people. Did you know that in the trials, more people died in the placebo arm than in the trial arm? In other words, of the 60,000 people that got Johnson & Johnson, more people had heart attacks or strokes in the placebo group that never even got the Johnson & Johnson vaccine than the people who died of those sorts of things, which people are going to die of in the trials no matter what, right? Because in 60,000 people, somebody's going to have a heart attack over the course of 6 months. So the important thing to remember is not the sheer number of people who died, but the comparison of how many died that actually got the vaccine versus those that didn't. And it's about the same, which means that we're just looking at the background amount. And then I think it's also important to note that when we look at data that goes into VAERS, and you may have seen people talking about how many reports of death there are after receiving the vaccine in VAERS. It's really important to note that a lot of those are people who would have died anyway and not related to the vaccine. You have to compare that number to the number of people who would die usually in time period. A good example of this was early on, there was a news article that said that 27 people in a nursing home in Norway died within 2 weeks of receiving the vaccine. And that was like, oh my gosh, that's a lot of people to die in a nursing home with only 100 people in it. And everybody scrambled to see what was going on. Well, it wasn't really a nursing home. It was a hospice that only admitted patients with less than a month left to live. And why they were vaccinating them for COVID, I'm not entirely sure. But every single one of those patients had a terminal illness and was expected to die within a matter of weeks. And so it's not really surprising that 12% of them died after receiving the COVID vaccine. It has nothing to do with the COVID vaccine. They were already dying of cancer or a neurologic disease or some other end of Alzheimer's disease, an end of life situation where they could no longer be cared for at home. So before you get too worried about these statistics about how many people have died, you have to compare them to the fact that people die every day, older people, people with a lot of medical problems, and that the vaccine actually isn't increasing that at all. The next category I want you to think about is this bad reaction or allergy. This is something to do with sort of not the intended effect of the vaccine, like having an allergic reaction to a component of the vaccine or having a reaction to something in the vaccine. That sort of thing is an unintended consequence. It's not how the vaccine is supposed to work, but it's something bad that happened to people. These are extremely rare. You heard in the beginning about anaphylaxis happening in some people in the United Kingdom, and we made a big deal out of it and watched people really closely. In the United States, we've had maybe a handful of anaphylaxis. We had one patient with a bad reaction out of 100,000 or more vaccines given. Actually, I think we're probably at 120,000 now vaccines given in our clinic, and that wasn't even very severe. Most places have none. And so this is and even people like me, I've had anaphylaxis many, many times to medications and to foods. And we have vaccinated tons of people like that and not had any problem with it. So this is actually a much lower concern. These vaccines are actually much less likely to cause allergy than penicillin or aspirin or ibuprofen. And so the drugs that you might take on a regular basis are much higher risk in terms of allergy than these vaccines are. Lastly, let's talk about side effects. Side effects are actually intensified effects that the drug is meaning to cause. So for example, if you have high blood pressure and I prescribe you a new medicine for high blood pressure and you come to the emergency room because you're dizzy and we find that your blood pressure is just way too low, that's because the medicine has worked too well for you. The medicine is doing its job, but you've had a side effect that it's worked too well for you. You've been too sensitive to it or for whatever reason. And so we need to cut back on your dose and be careful. It's not an allergy. It's not a bad reaction. It is just something that is a side effect. It is an anticipated and expected effect of the medicine that's just too much for you. This is something that happens a lot with these vaccines because we want to make the immune system sit up and take notice. And when your immune system does that, you feel it. It's the same thing as like when you exercise and then your muscles are sore the next day. That's expected. You may not like it very much, but you feel like you're building your muscles and getting stronger. Same thing. This is just your immune system getting better and stronger. So those sore arms, those chills, those fevers, the not really feeling very well after you get your dose, that's to be expected and it's good. The good news is that the people who don't have those also get the same effect from the vaccine. And we're not sure why some people do and some people don't. And we'll figure that out over time. But as long as those side effects aren't dangerous or causing too much harm, then there's no reason to not give the vaccine, especially when the effects of COVID are so much worse. So let's talk about what that means. We're learning more and more about the long-term complications of COVID. In the beginning, we thought, a lot of people thought, well, this isn't any worse than the flu. It only kills about 1% of the people that get it. Maybe that number's higher if I'm older or if I have other medical problems, but little kids and stuff, they don't really have any problem with COVID. They're fine. Well, that's a little bit true. It's certainly true that they are safer than older adults and people with other medical problems and less likely to have that. But let's take a look at what we know about adults that have COVID. Up to 30% of people that have COVID, even mild COVID, even asymptomatic COVID, go on to develop what's called long COVID. Many of these patients feel worse during their long COVID, where they're not contagious and don't actually have COVID, worse than when they actually had COVID. These symptoms have lasted up to 6 months. And the only reason I say up to 6 months is because it hasn't been long enough to know if they last longer. Now, there are things that we're doing to help treat these individuals. Some of them have actual organ damage. Some of them do not have actual organ damage. But this is difficult to understand. We don't know exactly why it's happening. Is this going to be a long-term autoimmune condition related to having had COVID? We're not seeing any of it after the vaccine. And that's really good news. We didn't see it in the trials, and we're not seeing it even now that millions of people have gotten it. Up to 50% of hospitalized adults with COVID ended up having heart damage. In a German study, 60 out of 100 individuals with mild COVID had heart inflammation in one study. So we're going to talk about myocarditis after the vaccine in just a minute, but it's important to know that COVID itself causes heart damage and myocarditis. We don't know whether or not these heart muscles are going to heal all the way. Now, children obviously do a much better job of healing than older adults and people who are hospitalized with COVID in the last year. But still, I have a son who's 12 years old, and I don't want to risk it with him. Then there's the 35% who have lasting lung damage even after recovery. That's not great either. The bottom line is that a small portion of these individuals are probably going to require heart transplantation or lung transplantation in the future. And that is the last thing I want to have in my kids' future. So that's where I am with it. And that's the last thing I want. So let's talk about COVID complications that we know about in kids. I've just told you about more of the adult side. So let's talk about this. There's an extremely rare but severe multisystem inflammatory syndrome that occurs in children. It happens about 2 to 4 weeks after the onset of COVID-19 and has been identified in both children and adolescents. There are a lot of cardiac complications with this. Inflammation of the heart, problems with the heart rhythm. These were most frequent in the people who had it earlier than the people who had MIS-C later. But it is definitely not great. Most of these kids survive and do just fine, but there is the threat of this ongoing damage, which we just don't know anything about right now. Of the children admitted to the hospital, which is probably in the order of 3 to 5%, although it's important to remember that the newer variants are more severe disease causing, and we haven't seen, because they're not circulating widely, but they could, and they are in some other countries, we know that younger children are being hospitalized more frequently with them. That means kids are at greater risk if we start having outbreaks of things like the Delta variant or more complications with the Alpha variant. So of those admitted to the hospital, 18% required an intensive care unit. And those who are very young and those who are adolescents were much more likely to need that ICU care. Those who have Black ethnicity also ended up in the cardiac or in the intensive care unit more frequently. And admission to the hospital for more than 5 days before they got sick made them much more likely to be ending up in the intensive care unit. That means that they were in the hospital for something else. Other complications in COVID-19 include fever, cardiac symptoms, and GI symptoms. That's even in the kids that don't end up in the hospital. And like I said, the newer variants are more dangerous and more contagious. So what are the COVID vaccine side effects? Well, most of them are exactly the same as in adults. You usually see pain, redness, and swelling in the arm where you get the shot, and the rest of your body can be tired. You can have a headache, muscle pain, chills, fever. Sometimes people feel nauseated, but it's not awful. My son is 12. He was vaccinated on the first day that he was eligible to be vaccinated, and his arm was very sore. And he told me he had a headache the next morning. I think this was mostly because he wanted to stay home from school because he seemed completely fine to me. Then when he got his second dose, 21 days later, because he got Pfizer, of course, he was pretty lethargic the next day. He told me he didn't feel great. He got to stay home from school that day, and he didn't do much. He sort of, didn't really want to do things and stayed on the couch instead of like scrolling off to his room to watch more YouTube. He was just kind of generally more sick, but he didn't have a fever and he did complain of a headache, but he did great. And he woke up the next morning and said, "I'm fine now. Am I fully vaccinated?" And I said, "No, 2 more weeks, honey." But that was my experience, and many of my friends have had similar experiences with their kids. So let's talk about the myocarditis issue, which has been seen mostly in 16 to 39-year-olds. There haven't been very many cases in the 12 to 16-year-olds that have been getting vaccinated over the last several weeks, and that's really good news. The rate is about 1 case in 5,000, and it's important to note that these are not myocarditis cases that end up in the hospital. These are kids that came to the emergency room with shortness of breath and chest pain, which is an unusual symptom in children and would prompt people to do an investigation. But what they find is that if they give them ibuprofen or Aleve or something like that, their symptoms went away and they were fine. And everything went away on its own in a few days. None of these kids have had very severe problems or long-lasting damage to the heart. This is just a mild self-limited inflammation. So I still don't want my kid to get that. And so I was really concerned about this. And so I'm going to repeat to you something that I heard Paul Offit say on NPR, because I think it's a really great comparison. So if you take 10,000 people between the ages of 16 and 39, mostly males, because males are higher risk than females, and you put them and you gave them all vaccine, 2 of them would probably get myocarditis. It would be mild. They might appear to their doctor for having, they might end up needing an EKG or an MRI and get some medication and feel better on their own. If you leave those 10,000 kids and you don't vaccinate them, then 1,300 of them would develop COVID. At least 1,300 of them would end up getting COVID. That means that about 1 or 2 of those kids would end up having MIS-C, or multi-organ system inflammatory syndrome in children. And of those, most of them would have COVID. And many of the kids, or many of them, would end up in the hospital and have myocarditis. And of the kids with COVID, about maybe 20% of them would have myocarditis as well. So if we're looking at the overall risk to your kid of having long-term heart damage, the risk is much, much greater in the unvaccinated group than it is in the vaccinated group. COVID is a nasty, nasty disease that we're only beginning to see what it's going to do to us in the long term. Now, don't freak out if you've had COVID. It's still going to be rare to have complications that last a long time. But when it comes to kids, they have a long life ahead of them, and we want to do everything we can to protect them. So I'll just start out some of the questions by answering some of the more common ones that I've heard. And then I'm hoping that you guys can put stuff in the chat and I will read them out and answer them, but I won't say who you are, so you can ask whatever you want. I don't know any of you, so it will be totally secret. But let's talk about that long-term safety. I think I gave you the update in the beginning that there's no reason to believe that there's going to be a problem. These vaccines degrade inside your body within hours of you getting the shot. They don't hang around, and they can't change the cells that already exist in you. You have your cells already pre-programmed to be what they are. And these only go into your immune cells and maybe kill off a few of the muscle cells in your arm. But aside from losing a few muscle cells in your arm, you're really going to be okay. Is there a microchip? No. First of all, they come in multi-dose vials. And so I wouldn't even know which microchip was going into which person. And so I'm not sure how we would track them. Plus, they're tiny, tiny needles. They're much smaller amounts than most of the vaccines that you've given your kids. There's no way there's a microchip in there, I promise. And they do not make you magnetic. Can you get COVID from the vaccine? No. There's no COVID in these vaccines. Now, some other countries do use some live attenuated or killed vaccines, but those are not available in the United States. You're not going to be able to do that here. Can you spread those vaccine particles, the spike proteins, to other people? No. The vaccine comes with a certain number of copies already in it. And so however many copies are in that 3 ml dose that you're going to get, that's the number of copies that your body can make. Your body can't copy that again. That's not how our cell systems work. And it can't go back into the nucleus and affect the DNA because it's just RNA. And I will spare you all the details about protein synthesis. But if you want to hear it specifically, I will go through it with you. But the bottom line is that those are copies. There's only that many copies that can be made. Once it's made from its recipe into a protein, it can't be used again. It gets broken up in the process. And so there's only that many floating around, and they get presented and broken down by our cells, sort of recycling processes almost immediately. Can the vaccine change your DNA? No, it's not possible for it to do that because it's all RNA and it doesn't have a reverse transcriptase polymerase in it that would allow it to actually even incorporate into your DNA. It just doesn't do that. Can you get COVID after getting the vaccine? Absolutely. Some people do. They're 90 to 95% effective. That means 5 to 10% of people are going to get COVID. But the reality is that those people are much less sick than they would have been. I'll tell you the story of an 82-year-old woman that we had in the hospital who attended a wedding with her husband and her son. At that, she was fully vaccinated, so was her son, and so was her husband. When they went to this wedding, someone was there who was not vaccinated and had COVID. Some people left the wedding that were unvaccinated and had pretty bad COVID. She was vaccinated. Her husband and son didn't get COVID at all, but she did. She picked up COVID from this person, and she went on to get so sick that she needed to be in the hospital. Now, a lot of people would look at that and they would say, what a failure of the vaccine. But I think we should look at it slightly differently. We don't know exactly why some people end up dying of COVID and other people don't. I mean, we know that if you have underlying lung disease or heart disease, you're more likely to. But that doesn't mean that some random 27-year-olds are not dying of COVID, because they really are. It's just that we don't know exactly which ones. That woman, even though she's 82 years old, probably shouldn't have gotten COVID, even if she'd gotten the vaccine. But the fact that she did means that she is, for whatever reason, in that group of individuals that doesn't do well with COVID infection. And she certainly would have died had she not gotten the vaccine before she went to that wedding. So I think we have to look at this as that, yeah, you can get COVID after you get the vaccine. You're really unlikely to, but if you do, you're probably in that group of people who wouldn't have done well with COVID infection to begin with. And that vaccine means even more to you. So remember that when you think about people getting COVID after getting the vaccine. Does the COVID vaccine affect fertility? No, there's literally no way for it to do that. It does not leave the local area of your arm. The fact that you feel symptoms all over your body is your immune system reacting. It has nothing to do with the vaccine. And there's never been any vaccine particles found anywhere near any of our organs. And it's important to remember that the eggs that women have are all formed by the time you were born. All of the eggs that you are going to turn into your potential children are already done being cooked. So there's no way that it's going to change any of that. And if you already had COVID, I told you before, this provides you with that memory boost and may actually provide even better immunity than it does for people who've never had COVID. You may be able to get out of getting a booster someday when we learn more about it. So that's all that I want to do today. There's a couple more slides in this deck, but I'm going to end the show because I think that's the key part. And I'm going to stop the share here so that I can see the chat. And I'm hoping that we'll get lots of questions. So I'm going to start here. Is it true that COVID vaccine will need to be administered annually or semi-annually? We don't know yet. So I don't think semi-annually or every 6 months is very likely because it's already working longer than that in most people. So I think the Pfizer vaccine trials did start giving people boosters at 12 months, but that's not because they were starting to fail or get COVID. They just thought that 12 months was a reasonable time frame, and they for some reason, which they have not told anybody yet, thought that people would need a booster. It may be, remember that in the future, these vaccines may not be free, and the more vaccine you need, the better it is for them. So don't leave that out when you're thinking about why they're telling you to need a booster. But we will go through that, and the FDA is not going to approve extra boosters that people don't need. So they decided to start trialing it and see what happens, and that's ongoing. But at this point, we don't know whether or not people will even need annual boosters. People who got vaccine trials last year in the fall, who were part of vaccine trials, are still doing fine and seem to still be protected. So I don't think that this is an emergency, and it's really important that we get everybody their first round first before we start worrying about that. But we probably will need a booster at some point if you never had COVID. If you had COVID and you got the vaccine, you may not. And then if there are variants that happen to escape the immunity, which so far there are not any, there are no variants circulating that are where the vaccine doesn't work. Now, the vaccine doesn't maybe work quite as well for a couple of them, but it works well enough to still protect people a lot more than they would have been protected without the vaccine. So if you think of it instead of as an on-off phenomenon, but more as like a sliding scale or like a spectrum, it may be slightly less good, but it's still going to provide you with a lot more protection than you would have had without it. So at some point, if there's a new variant, we would all need to have a booster that is for a variant that just the vaccines don't work at all. But right now we don't have that. And the more people that get vaccinated, the less likely we are to have that. What is the timeline for vaccinating kids under the age of 12? So the best that I've heard is that September is the target date for Pfizer to be prepared for 6 months to 12 years old. Now, it takes longer to develop or to test in the 6 month to 12-year-old age group than it does 12 to 16. And that is obvious to me, but probably not obvious to all of you. So 12 years old and up often just receive the adult dose of any vaccine. It's all the same from about 12 and up for all of us. So you get the same flu vaccine. Actually, flu vaccine goes down to age 3. And MMR, same thing, lots of things. So you don't need to worry. So it's very easy. They just need to get a bunch of kids in, make sure they do okay with the vaccine. They do not need to reprove efficacy because children's immune systems are not likely to work differently. They need to prove safety again. And so they have slightly different targets and things that, like, sort of the work and the data that they need to collect. The good news is that in those trials of 12 to 16-year-olds, the vaccine was even more effective than it was in adults, and very, very safe. And in fact, it seems they have fewer problems, although they may be more likely to have systemic, like sort of feeling fatigued and tired after that second dose, but they are not more likely to have any of the more severe things like the myocarditis that we talked about, things like that. So the good news is that that trial went really well. I expect that the 6 month to 12-year-olds are going to be just as smooth when it comes to safety and efficacy. The thing is, we got to figure out the dose, and that dose is really what matters in terms of the side effects and sort of titrating those side effects to make them as tolerable as we can while still providing an effective vaccine. And so I think that's what they're working on. We know that those trials are largely finishing up now, but we haven't seen the data. Remember, everybody that participates in these trials is blinded. So you don't know whether the kid in front of you got vaccine or got placebo. And so you have to consider, like, even people who are working in these trials, of which I have many friends, they can't tell us anything about the efficacy because they don't know which kids are in which group. So we'll know more after that data has been released, but it just hasn't been. I would like to see them go. I expected, there's also part of this question asking me about, would they just do 9 and up, 5 and up, toddlers and babies? And I actually thought that they were gonna do 6 to 12 next and then do the 6 months to 6 years. And I'm surprised because they enrolled it that way. At least some of the studies enrolled that way. But I think what is actually gonna, it looks like what Pfizer said they're gonna do is they're gonna apply for 6 months to 12 years all at once, or 6 months to 11 years old. So they must be further ahead than we thought. And they said that they expect September. So it will certainly, and in the vaccine race, they have been under promising and over delivering all along. And so I would hope that it's going to be sooner. Certainly with the 12 to 16-year-olds, they were saying July, August, and we were hearing in April, we were hearing it'll be in the next few weeks. So I think it's probably not in the next few weeks because I would have heard by then that it was basically the data was finished and we would start seeing like sort of like early indications from the researchers. So it's probably not in the next few weeks, but I think everybody wants that to be done before we get to the school year. There's also a question here about what percentage of school age kids is needed to prevent spread in classrooms and schools. It's really important to remember that vaccines are just one layer in the protection strategy here. And I realize that the CDC has sort of gone whole hog on vaccines and said, if you're vaccinated, you're good to go. You don't really need any of the other protections. And that is definitely true right now, especially with the low numbers we have of COVID. But the reality is that the number of people that need to be vaccinated in order to prevent spread is a little different if you're talking about people living closely together in close quarters in a nursing home versus being outside at, walking at the park versus being in a crowded space versus being indoors in a dry environment in the winter. And so all of those, this idea of herd immunity is having enough people with immunity, however they got it, that even the people who aren't immune aren't able to get COVID and spread COVID because the disease doesn't have anywhere. It can't pass itself along because there's not enough susceptible people. That is actually sort of a fluid concept. And if you look at the outbreak of measles that happened in Disneyland some years ago, the rest of the country is largely at plenty of measles vaccine, that we didn't have a sustained outbreak of measles across the entire country, but it dipped below whatever was needed. And there was an introduction of measles in that community. And that's what resulted in spread. And the spread only happens in the unvaccinated community. So I would say it's hard to answer the question, what percentage of school age kids is needed to prevent spread in classrooms? Because the kids who are vaccinated aren't going to get COVID. The spread is only going to be amongst the unvaccinated. And so you can look at this from an epidemiological standpoint and say, I guess it depends on how many cases I can tolerate. But if it's your kid and yours is the unvaccinated kid, then you may not want even one case in your unvaccinated kid. But there's no real way, given the way that CDC has gone about doing this after the vaccine, of really providing protection, because we've kind of taken away a lot of the other layers like masking, distancing, ventilation. A lot of those things, sort of aside from the ventilation because we're outside more, a lot of those things have been largely taken away in public spaces. So I think it's tough for parents of kids under the age of 12 right now to decide what to do. You have to be careful. They really are still susceptible to COVID. There is that Delta variant spreading around. And that's not something that I want my kid to get. I breathed a heavy sigh of relief when he was 2 weeks after his second dose of vaccine, because I was worried about these things. I think in schools, the vaccinated kids are going to be good. The unvaccinated kids, it's not going to take very many in a classroom for them to be able to pass COVID from kid to kid to kid. If your unvaccinated kid is around other unvaccinated kids, that's enough people to spread COVID amongst yourselves. That's all it takes, really. This disease is pretty transmissible and pretty bad. If your kid is unvaccinated, but is only around vaccinated kids, you're not going to get COVID. You have to have introduction into a pocket in order to have that spread, but then it doesn't take a very big pocket for there to be diseases in that group. The idea of herd immunity means it's not going to spread throughout the country, but that's not really what you're thinking about when your kid is in a classroom unvaccinated with 3 other unvaccinated kids. You're really just worried about that classroom. And that is a tougher thing. It's all going to depend on who your kid's friends with, who they get assigned to recess, who they play with at recess, who's in their reading group, and all of those things. And that's not stuff that you can control as a parent. So the best thing to do is to get these kids vaccinated, or to use the other measures like face masks, distancing, and all of that. And if you have so many people that can't be vaccinated or won't be vaccinated, that you have sort of a vaccination rate of less than 80%, maybe even less than 75%, or maybe less than 90%. We'll learn that, because I don't know for indoors in the winter when things spread, COVID spreads a lot more efficiently and effectively. You're probably going to want to be using all of those other methods, like the distancing when you can't be masked, masking, and being extra careful with ventilation, and keeping people in cohorts, cleaning things down, and being extra careful. There's not an easy answer to that question. I have another question. If the kids feel awful after their dose, will giving them a fever reducer like Tylenol or Advil reduce the efficacy? So this is really, this is a really interesting one. So there's one study in children that suggests that if you give them Tylenol or ibuprofen before they get a vaccine, and this is actually, I think, for DTaP, that it didn't work as well. They didn't make as many antibodies as the kid who didn't get Tylenol or ibuprofen before they got their dose. But if you gave the dose after, if you gave them Tylenol or ibuprofen after they got the dose of the vaccine, then everything was the same, no problem. Even if it was just an hour after, which doesn't really make sense. And so it's not clear. And those kids that got the Tylenol and ibuprofen had still really great antibody responses. They were just statistically significantly slightly lower than the kids who didn't. And so for this reason, we often tell parents to get the optimal vaccine experience, don't give your kid anything beforehand. If your kid always has a bad reaction to vaccines, give them Tylenol before they have their vaccine and do not worry about it. It's better than not. But if they get sick after, you don't need to worry at all about giving them something afterwards. I offered my son ibuprofen and he said, no, I feel kind of nauseated. I'll just have more Gatorade. He never gets Gatorade otherwise. So I think there is he didn't want any. Do I think that children will get the vaccine at their pediatrician or specialist offices? I hope so. Now, many places are now sort of getting online and being able to provide these things, but it still may be difficult. And there's plenty of vaccine now that we don't have to worry about the wasting issue, but it still may be on a vaccine day. So because they're multi-dose vials, and once you open the vial, you have to use all the doses at once, there's probably going to be vaccine days. The way that we handled it at the lab school at University of Chicago, which is where my son goes and where I've been working with them, is we did a Saturday for 12 to 16-year-olds, and everybody, we just said, just sign up and come on this first Saturday, and then 3 weeks later we did another Saturday, and otherwise they could come and get vaccinated at our clinic. Most sort of large offices will probably have a space where they sign up people for vaccines on Tuesdays or something with respect to this. And so, yeah, you may be able to get it there, but probably not. I would not expect that this is not the kind of vaccine where you're in for something else and you can be like, oh, hey, could you just throw in the vaccine too, like the flu shot, where you're like, I'm going to be there anyway for my, I don't know, my asthma checkup, so I'll just get my flu shot then. No, it's going to have to be probably scheduled so that the vial can be used appropriately. There are still millions of people across the world that need those vials, and we have a social responsibility to use all of our doses and not just give one and throw the rest away. That would suck. Okay, any additional questions from anybody? We're at 4:49. I managed to talk for like nearly an hour. I'm really good at that. Any other questions at all from anyone? Yeah, I would strongly urge you to get your children vaccinated and to talk to your friends and colleagues about getting vaccinated. The information that we're getting from OSHA, from CDC, from a lot of these areas is really pushing for organizations to have mandatory vaccination policies. And as much as we like to see vaccine as a choice, our choices when it comes to infectious diseases affect other people around us in a way that is it's much deeper than what we want it to be or what we think it is. This is, what I study and what I look at every day in my life, and I see the collateral damage from infections that spread unintentionally every single time. And I know it's sort of, it would be easier if we could just look at this and say, oh, it's just like flu. But to be perfectly honest with you, I watch children and adults and older individuals die of influenza every single year. And I hear people say, well, it's just like flu. And I think, please, could we just do flu right too? This is an opportunity for us to try and value human life in a way that we don't always do when we're thinking about infections. And I'm really hoping that we can use this as an opportunity to understand what our impact is on others around us and not just think about ourselves. Okay, I managed to sort of go on long enough to get another question. So that was good. What will happen when kids get colds in the winter? Will this impact getting the vaccine or continuing to assume they have a COVID, so need to test them? So that is a great question, Patrick. And I will tell you, I have some answers from the most recent OSHA document, the most recent OSHA rules that were sent out for hospitals and healthcare organizations. So as you know, right now, if you have any sniffle at all, you're not welcome in any public place. And yes, when we start putting kids back into classrooms or when we start hanging out in places indoors without masks on, colds are going to spread again because we don't have immunity to those. We have immunity to COVID, those of us who are vaccinated. So it's going to be really confusing. The most recent guidance that we have is telling us that in vaccinated individuals, we don't need to be nearly as concerned about whether or not they have COVID. And so there may be sort of a tightening of the restrictions, sort of like sort of a higher set of symptoms. For example, if your kid loses their sense of taste or smell, they need to be tested for COVID. But if they're just sniffling, maybe they don't. If they've been vaccinated, because vaccinated individuals with mild COVID symptoms often don't have very high viral loads and don't spread to other people. For this reason, we may need to go to asking them to wear a mask when they have cold symptoms, but they can still attend school, and only needing to get tested if those symptoms last for more than a day. That sort of thing are options and places to go. That is not what I'm advocating as a policy. I am merely saying that we have a lot more options on the table for vaccinated individuals. For unvaccinated individuals, those rules are going to be the same. If you're exposed to someone with COVID, you're going to get stuck in quarantine. If you are in a classroom with someone that has COVID, you're going to be stuck in quarantine. You're going to be needing to wear a mask indoors, especially in school. And everybody's going to want you to do that because the vaccinated kids don't want to get breakthrough COVID they don't want to get COVID and bring it home to their families either. And they're going to also be made to stay home with even the mildest of symptoms. So there are a lot of social and sort of other life advantages to being vaccinated that, while some people would say it's not fair to treat vaccinated kids differently than unvaccinated kids, and why do the unvaccinated kids have to have all these disadvantages? But the reality is that that's how we're we're setting things up like a two-tiered system. That's what the government has decided. That's what our public health agencies have kind of decided. And so I think you should expect that there are going to be things that change for your kid and you if you're not vaccinated. And I know a lot of people don't like that. It feels like it's kind of anti-choice, but the reality is it's still a choice. You just don't like what you chose. Do I expect schools to require this vaccination at some point? Yes, I do. I think that, but I don't know that it's going to be this fall. So I think that most places want to let people, the best advice when it comes to making things mandatory or not mandatory is to get everybody on, as many people on board with as many carrots as you can before you bring out any sticks, especially because we now know that schools can be open even with widespread COVID when kids are not vaccinated. But the parents in the schools have to be willing to do the things in order to mitigate transmission. And in places where they don't want to wear masks, keep distance, ventilate, and eat lunch alone, then they're going to want to require vaccine earlier. And so it's going to be hard. There are going to be people who wish that we did more masks and less mandatory vaccine, and other places where there's going to be more mandatory, and where there's going to be more masks and less mandatory vaccine. And I think that this is going to evolve organically over some time. I don't think there's going to be some giant rule that comes out that says all schools have to mandate vaccine. The Illinois could do that, but I don't think they're going to. I think it's going to be up to individual places how they're going to handle this. And I think it's going to be a tough call. And I think we'll learn a lot from this fall and seeing how things happen when everybody starts going indoors. And that's going to really inform what we do with kids.